So I'm Amy Baltes. I am a second-year Master of Public Health student here at UW. I'm also one of Randy Brown's research coordinators. So for my capstone project for my Master of Public Health degree, I looked at predictors of skin and soft tissue infections among people who inject drugs in rural areas in Wisconsin. So we'll kind of go over some introduction on the skin and soft tissue infections and then move into the methods that we use for question development and survey administration, and then follow that up by some of our results and discussion. So for introduction, the opioid epidemic disproportionately affects rural areas. So to put that into context, for Wisconsin, 30% of our population lives in rural areas. And 70% of Wisconsin counties lack any opioid treatment program or licensed buprenorphine provider. They also have limited access to care and prevention methods in these areas. And then skin and soft tissue infections are a leading cause of morbidity and mortality among this population. Oftentimes they have complications that can lead to sepsis or endocarditis, or just more severe infections in general that require further medical treatment. And common skin and soft tissue infections in this population include skin abscesses, cellulitis, osteomyelitis, or infectious endocarditis. These infections are primarily caused by Staph aureus in the skin flora, and prior research has shown that people who inject drugs actually have higher rates of colonization of Staph aureus in their skin flora than the general population. So this actually predisposes them to a greater risk of infection while injecting. So the questions that we administered were part of the greater Rural Opioid Initiative study, and that's run by Dr. Ryan Westergaard out of the UW Infectious Disease Group. We administered this survey at 6 different Vivant Health syringe exchange programs, previously the AIDS Resource Center, Wisconsin. And those included Appleton, Eau Claire, La Crosse, Green Bay, Superior, and Wausau. And for question development, we found this bacterial infections risk scale for injectors, the BERSI questionnaire, and that was based out of Colorado. It was a 17-item scale, and it was used to assess specific behaviors that were expected to increase individuals' risks for acquiring SSTIs based on prior literature. So we kind of looked at what they did and then adapted that into questions that we wanted to ask and added some further content. So we added 13 questions to the Greater ROI Study Survey and administered those between May and July of 2019. And our questions focused on skin cleaning, water sources, anatomical location of injection, the injection type, so whether subcutaneous, intramuscular, or intravenous. And then we also looked at drug of choice, infection history, and treatment types. So between May and July, we collected a total of 80 responses. We used chi-square tests for categorical non-ordered variables and then regression models for the categorical ranked variables. We estimated SSTI history and prevalence based on whether or not a participant reported having an infection within 1 year prior to answering the questions. And then we compared that prevalence to participant characteristics, demographics, and injection practices. So we found that most respondents were Caucasian males between the ages of 30 and 39. They most often received high school diploma or GED and were often covered by Medicaid. They also, majority of people responded saying they had unstable housing within the 6 months prior to response. So that includes moving from place to place, couch surfing, living on the street, in a car, park, abandoned building, squatting, or living in a shelter. Interestingly enough, this survey was originally focused on opioid use, but we found that 50% of respondents reported methamphetamine as their primary drug of choice, while 25% reported heroin. But at first this was kind of shocking, but then we realized the incidence of meth use throughout the state is increasing, so we weren't too shocked once the survey continued on. And a total of 18 individuals out of the 80 respondents reported a history of skin infection. We also found that females were 3 times more likely to have a history of skin infection, and prior literature suggests that females are more likely to initiate their injection drug use after being influenced by other females, and they're also more likely to rely on others to inject for them. citing their inability to inject themselves and difficulty finding an injection site as the primary reasons for having someone else inject for them. So this could lend to that. We also found several behavioral practices that were associated with infection. So for example, people who use sterile skin cleaning methods prior to injection were less likely to report a history of infection. Sterile skin cleaning methods include alcohol pads, soap and water, hydrogen peroxide or Purell versus just using tap water, saliva, or never cleaning their skin before injecting. We also found that people who infrequently wash their hands were more likely to develop or report a history of infection. And another behavioral practice was the sterile water source. So for people who use sterile water sources, they were also less likely to report a history of infection. And we included sterile water sources as purchasing it from a store or getting it from a needle exchange program versus non-sterile sources being tap water from either their home or a public bathroom. We also asked if people had ever used toilet water, but nobody had reported the use of that. For injection sites, we found that people who injected subcutaneously or skin popping or intramuscular or muscling were more likely to report a history of infection than those who injected intravenously. And those who found their injection site on their first attempt were also less likely to report a history of infection compared to those who required multiple injection attempts before being successful. Contrary to other past literature, we didn't find any anatomical correlation, but we did find that people who injected into their hands or upper arms were more likely to report a history of infection compared to those who injected in their cubital fossa. And lastly, there was, again, contrary to prior literature, we didn't find a frequency of injection correlation. So in other words, people who injected on a daily basis were no more likely to develop an infection compared to those who injected on a weekly or monthly basis. So for the individuals who reported a history of infection, they cited several treatment methods. So many of them, the top three are those treatment methods that can be used at home, and then the bottom five are those that were medical treatment methods. So many people reported using a warm compress at home or over-the-counter medications, and also draining the abscess at their home by themselves. And then again, many people reported going to the ED or urgent care using prescribed medications, and then a few also cited having procedures in the ED or surgical intervention, as well as one person said that they had an inpatient hospital stay related to their infection. So overall, there were several higher risk injection practices that were common among participants who reported a history of skin and soft tissue infections. And based on our results and prior literature, it suggests that rural populations partake in similar risky behaviors as the urban counterparts. And then based on what we found, we believe that future studies should potentially look into understanding the socio-demographic and cultural factors that influence risky injection practices, particularly among females, to verify that literature. And then also just looking at general barriers of safer injection practices related to preventing infections, and potentially even focusing on the rural populations themselves, given the lack of care and treatment methods that they have access to. And then lastly, just looking at the increasing incidence of methamphetamine, potentially looking at the different injection practices that are involved with injecting methamphetamine versus injecting other opioids or substances, and how that may relate to skin infections. And then also based on these results, we recommend that educational materials should target people who inject drugs that are not in treatments. Potentially healthcare practices should implement tailored education that surrounds wound education, or when it's appropriate for individuals to do at-home treatment versus seeking medical treatment, given the extent or severity of their infection. And then syringe exchange programs also serve as a cornerstone of prevention, and they're potentially an avenue to implement education to their clients that could be different from the wound education or similar to it. The limitations of our study: it was a one-time cross-sectional approach. Recall bias could play a role in the prevalence rate or other responses. And again, we had a small sample size of just 80 individuals. However, we're hoping to replicate this on a larger scale with the second phase of the greater rural opioid study.